My name is John Samet. I'm at Lurie Children's in Chicago, and we'll talk about MSK Ultrasound. So I think the first question you might want to ask yourself, and you might get asked, is why do I do MSK Ultrasound? Why should I do this? And I'm going to take you through some examples here to kind of show the power of MSK Ultrasound and hopefully try to convince you its value. So this here, as you can see, is a pretty easy case for MR, right? For those who do MSK ultrasound, there's a cystic lesion between the semimembranosus and the medial of the gastroc, shows only rim enhancement on post-contrast. This is just a Baker cyst. But what I didn't show you is that this was a 5-year-old who was under general anesthesia. And so to me, this is kind of heartbreaking to see this case come across the list because you can diagnose this very easily with ultrasound. And so, as you know, ultrasound has no sedation, no contrast needed, but it does take skill, right? You have to learn how to do it. And once you can become comfortable, you can basically spare this child a really invasive imaging test. So I think it is very important to learn how to do some of these things. We can do dynamic evaluations, right? What this is, and you can watch this clip, is a patient with paresthesia, so some numbness and tingling in the pinky finger, right? So you think to yourself, what nerve distribution is that? So remember the ulnar nerve. And what we're doing is we're scanning transversely over the cubital tunnel right here. And this bony prominence is the medial epicondyle. And so as they're flexing their arm up, you're going to see that nerve pop out over the medial epicondyle out of the groove. You see kind of quickly like jump over there. And so that's something that you can't really see with MR. So you have dynamic evaluation. How about evaluation of masses? I'm sure we've all seen this kind of case on MR. We have this sort of ill-defined mass with multiple little septations, hypoechoic areas. With compression, we show that it like really dramatically reduces in size. And that's very helpful to show that this is probably a venous malformation. I'll show you the color picture later, but if it was a sarcoma, I wouldn't really compress away like this. And it just gives you that just extra piece of information that you don't get with MRI. Here, you also can do Valsalva maneuver depending on where the malformation is. And you can see here that you have this mass, which totally filled in increasingly with a Valsalva, showing that it's a venous structure. So for example, if you were thinking, is this a lymphatic malformation or is this a venous malformation? Well, lymphatics wouldn't really fill in like this, right? You would have what kind of looks cystic, like it wouldn't be as compressible, like a little bit compressible, but venous malformation will compress and they'll fill in with Valsalva. So really helpful to give this extra information with dynamic ultrasound. Speaking of other dynamic things, let's talk about the ulnar collateral ligament of the elbow. It's a tricky area. We're often asked to evaluate it on MRI, on ultrasound, but mainly MRI, right? And the classic is a patient who is a pitcher, baseball pitchers. Kids are pitching more and more and more. I think nowadays, I know for my own kids, they have limits to how much they can actually pitch, how many numbers of pitches they can do, because this ligament is just so prone to injury. So what you're seeing here is you're putting the probe basically in longitudinal along the medial elbow. And this is superior, this is inferior. Let me just go here. So what you're seeing is the medial epicondyle. This is the distal humerus here. This is the joint line, right? And so you can tell it's a fan-shaped ligament, beautifully you can see it. And it tapers, crosses the joint and attaches to the sublime tubercle of the ulna. Now let's look at another patient who has an injured UCL. So this is flipped the other way. So this is the patient's head, this is the patient's feet. And you can see the ligament is thickened, kind of hypoechoic. and it then will attach to the sublime tubercle. Now, but what about stability, right? So we didn't really tell them that much. We said that it was injured. We don't see an obvious complete rupture, but what else can we tell them, right? Because they have to decide if this is moving without my clicking. I'm sorry about that. What we're doing is looking at this area here. This is the analogous to what we're seeing on ultrasound, right? So we're looking right here, and we're going to give them more information now. So we're going to gently stress the elbow, and we're looking at that joint line. All these little air bubbles here that are appearing. But what you can see is that even though we didn't see a rupture, as we stress the elbow, and you can do this yourself or have a second person, or I had when I was starting to try to convince orthopedists to do this test, I actually invited the orthopedic surgeon to the ultrasound, and it was, I said, you can do the stress, so I don't have to worry about hurting the patient. And so what you can see here is that the joint widens significantly, and there are numbers out there to help you decide what's normal, what's not. Over 1.5 delta is a number that's out there. And so this gives them more information to say, okay, the ligament, we saw something, but it's really insufficient. It's not doing its job. So on MRI, you might just see thickening, but not really give them that piece of information. So this might be a surgical case then. Here is a static image just showing again what this might look like. You have, without valgus, we measured it, it was 5 millimeters, the joint line. This is with valgus, and it measures 7 millimeters. So it went up by 2. And so if it's over like 1.5 or so of a delta of a change, then that's considered abnormal. We always compare to the other side as well, just to kind of get a baseline for each person. But this was a nice case to kind of confidently say, hey, there's some insufficiency of this ligament. And so that added value above an MRI exam. How about dealing with MRI artifact? I'm sure you've gotten MR cases where there's metallic hardware and it's going to be all this artifact, very hard to see. So this patient had a history of an elbow dislocation and fracture, was treated for that, had hardware in place, but during the treatment, physical therapy, they noticed that actually had ulnar neuropathy. So then was now seeing a neurosurgeon to evaluate for that. And what you can see here is they came there for MRI. I was actually on the weekend. They got this, could barely see the nerve. The nerve is here. Doesn't tell them any information. Very difficult. I offered to do an ultrasound, brought the patient back down the same day, and I'm going into the cubital tunnel again. And you can see here that this one fascicle, and we'll have a little bit more on nerves later on in the talk, but you should have a nice honeycomb appearance with similar appearing sized fascicles. This one you can clearly see is very enlarged, and has ended up being a post-traumatic neuroma, which is kind of like a scar ball of the nerve. And so that focused ultrasound image of the area really added value over the MR. So often they're complementary. So this is a really nice case to show the use of ultrasound. And what I also do, this is me here, I will then offer myself to go to the OR. So for example, this is another way you can start up your practices, is if you kind of talk to your peripheral nerve surgeons and you offer this, they're very happy because they previously didn't have anyone to kind of image their studies. This is just a very tricky area. They do the EMG, the nerve conduction studies, but what they want help with is where is the actual neuroma, right? They know that the electrical abnormality is somewhere in a certain area, but if you can show them where the actual nerve injury is, they can limit their incision, they can limit the OR time. So for example, one, it will limit the OR time. Two, that can help them plan, do they need a nerve graft? If it's like a complete rupture, they have to do a sural nerve graft, so they have to prep the leg as well. So you can really add value, and I'll go up there. Often they'll have me scan before the patient is open, so the patient's asleep. Sometimes they call me back when the patient's open. I don't like to see that. But you can kind of scan over the area, mark the skin, show them exactly where the neuroma is. In this case here, you can see the fascicles are sort of normal, and it kind of becomes nodular and thick, and you lose that neural architecture. And so they mark the skin, we mark it with them, and then they know exactly kind of where the abnormality is. This is another high yield area that I think you can get involved in. besides nerve injury, tendon injury. So nerve and tendon laceration is a really good place to start. It's sort of low-hanging fruit because, like, for example, this case was a 3-year-old who reached over on the counter and there was a knife and accidentally lacerated their thumb. Terrible story. The orthopedic surgeon called me. We talked about the case, and orthopedic surgeons, they have some of the best physical exam skills of like any physician, I feel like. They often, they're doing based on just x-ray alone going to surgery. So if you rupture or lacerate your flexor pollicis longus, and you literally can't even move your thumb, they're pretty sure that it's ruptured. But this is the perfect case to offer to do ultrasound because they're going to the OR anyway. So again, I invited the orthopedic surgeon into the room, showed normal versus abnormal. You can clearly see this tendon stump. Instead of seeing like a line going all the way across, you see a rounded kind of blind ending thing. This is an empty flexor tendon sheath. And he was very convinced, and it just makes them feel better, right? So they, for them to have just that extra ounce of confidence, I think that's really what it is. To know that when you open up the hand, you're going to see what you expect. And so this is another example where you can confirm a clinical suspicion, avoid MRI. And it's really nice to compare to the other side as well. Another example, this was a basketball player who they had a suspected Achilles tendon rupture. And so, instead of having to do an MRI, you can do an ultrasound. You put the patient prone on the bed, have the feet kind of hanging off. You can do a little bit of dynamic things as well. So you can clearly see the Achilles tendon is ruptured. And what you typically do is you measure the tendon gap. And so depending on the age of the patient, I also do some adult work as well. If they're going to possibly do a non-operative treatment, they want to see that it can gap down, so to speak, to less than a centimeter. And so if the gap is really wide, they have to go to surgery. But if the tendon is torn and they're very close together, they could theoretically offer non-operative treatment depending on the patient's clinical status. So here's just an example of avoiding an MRI for Achilles tendon rupture. Chest wall masses. I'm sure you guys have all seen this. I think it's nice to be able to avoid an MRI or a CAT scan. Here you can see when you scan right over the bump, the rib is kind of protruding more than it would. And this hypoechoic area that are marked by the arrows is actually the cartilage cap of the osteochondroma. And so it's nice to be able to just kind of put that to bed and tell them it's an osteochondroma and then be done with it. How about finger mass? Very common to get lumps and bumps. This is just an odd one. It's good to have seen this. So the flexor tendons have tendon sheaths, of course, and sometimes you get a little tiny, probably micro tear, and fluid will seep out of the tendon sheath, and you get a what's called a retinacular cyst or a flexor tendon sheath ganglion cyst. And what's funny about these, it just looks like a weird thing. It looks like a cyst sitting on top of the tendon. If you haven't seen it before, you kind of can't really explain it. Why is there a cyst just randomly there? But as it turns out, they're most commonly at the level of the A2 pulley, which is over the proximal phalanx. So it's far and away most common to see this abnormality right over the proximal phalanx, and it looks like it's just sitting on top of the tendon. You don't usually see a fluid cleft or anything. So being able to see a cyst, show that it's anechoic, no vascularity, and that this is just a ganglion cyst. This is an odd one, but I feel like we see a few a year, and it's always very puzzling to the referring provider because it's pretty uncommon. But this is a ganglion cyst in a very unusual location. So if you ever see a mass in the region of the sternoclavicular joint, think about sternoclavicular ganglion cyst, and it's just a cyst, just as you would in any other area. And so just something to kind of keep in the back of your mind. One thing here that's very nice, you might think neurofibroma, what's the big deal? Why do you need ultrasound for that? But I actually think when you're faced with an unknown soft tissue mass, so you see a mass in ultrasound and you say, okay, it's solid. This is not a cyst. This is not a vascular malformation. If you just call it a solid mass, well, the possibilities are like pretty vast, right? Um, a soft tissue sarcoma is like the worst kind of case scenario that you're worried about. But if you can document that there's a nerve going into and out of a mass, to document that it is a neural origin, as in this case shown in the orange arrows, it dramatically limits the differential diagnosis. So a nerve sheath tumor is most likely benign, neurofibroma, schwannoma. Yes, you can have malignant peripheral nerve sheath tumor, but if you just see a small ball on a string and you can say, hey, this is neurogenic, it makes it much less likely that it's going to be a rhabdo or a synovial sarcoma and whatnot. So I think it is very helpful to show a neurogenic origin. So you should try to look for that if you are faced with a mass that is along a neural plane. This is another cool one. So patient had a history of remote fall, but had this bruising that just never went away. What we're seeing here is what you might at first just say, oh, it's a non-specific collection, is this an abscess, a hematoma, but the injury was like months before. What you can see here, unlike a regular collection, it's sort of right at that border between the deep subcutaneous and the fascial surface of the muscle. And that location, you should think about this entity. It's a shearing or degloving or close injury where you fall, the tissues kind of shear really quickly and they tear up lymphatics, blood vessels, and whatnot. Injury to the fatty tissue. This is known as a Morel-Levelay lesion. And one of the kind of pathognomonic findings of it is these fat globules. So if you ever see a collection at a myofascial surface, you have some history of a fall, and you see these fat globules, suggest Morel-Levelay. And the reason it's important to bring this up is because unlike a regular hematoma, these can persist. They're very difficult to treat. They may never go away. And most people haven't heard of this entity. So if you suggest this, you can recommend your IR colleagues, for example, ours, if they hear Morel-Levelay, they will talk about, not just draining it, but sclerosing the lining and trying to cause it to basically scar down. So it's a very different treatment. Another one here is lump and bump in the musculoskeletal area. You're seeing this subcutaneous mass, has some little punctate calcifications and shadowing. And this was a pilomatricoma, which is sort of this benign like tumor, like hair follicle or appendages or whatnot. See it in the extremities and head and neck kind of area, chest. And so it's a good one to kind of know about. Quickly diagnose joint effusions, right? For infection, for arthritis, I think it's good to train your sonographers how to find a joint effusion in all the major joints. So we're all used to doing hip effusions. Our sonographers are amazing at finding hip effusions. But when an elbow comes across, people get like really nervous. They don't know where to look, where to put the probe. And so that's like a very high yield thing to do. And I've trained our sonographers. We just went over all the biggest joints, where to look. And once they kind of feel comfortable with that, then you can do scans from the ED, all these other things. So this is just two examples here. One is of a knee effusion, where you can see the quadriceps tendon attaching here. And what you see is fluid going between these two fat pads. It's very interesting. So you have the prefemoral fat pad, and you have the retroquadriceps fat pad, and the fluid always goes in between those. A little bit of fluid is normal, but once you start getting a little bit more than just a sliver, it will be abnormal. Here's an example in the elbow. So we look from posterior, and you can see here that the triceps tendon, this is the back of the humerus, right? So the olecranon fossa. You look right over here, you see a big joint effusion, synovitis, hyperemia. This was juvenile idiopathic arthritis. Okay. How about troubleshooting? So this is a rare case, I understand, but it just shows that ultrasound can really help in some of these problem-solving scenarios. So this is a patient who had a both bone forearm fracture, as you can see here. We kept reading the follow-ups and just never quite healed. Kept seeing some lucency there. The patient also had like a muscle wasting on the thenar eminence, had like some kind of problem in the median nerve distribution. They couldn't totally figure it out. And we offered to do an ultrasound. And so this is a transverse clip. And what you're going to see here, so here's the median nerve. kind of right in this area here. And I'm going to play this clip for you to see if you can see what's going on here. So I'm going to be tracing the median nerve, and you can see that the nerve is doing a very abnormal thing here. It is basically tethered to the bone. It's entrapped in the fracture site, which is pretty rare. It has been reported. What they ended up doing after this was they went to the OR, they detethered it, and they actually were able to release the nerve and not have to do a nerve graft. And so the patient was able to have his nerve spared. So really cool problem-solving case there. This is a patient who had a popping sensation. I'm sure you've had to read some of these every once in a while, and you're not really sure what to say about it. Sorry, I don't know why it keeps going ahead of me. So we do the arms up, arms down. You radiate them two times. We didn't really find anything, but the patient swears up and down they have an abnormality. They have a popping sensation. This patient actually was trying to reach the dog that ran away from them, and they grabbed the leash, and their whole extremity was stretched. So the surgeon, didn't want to do some major surgery without having some confirmation. Again, like you might say, well, why do you need this? But it's just, no one wants to just go to surgery based off of, a possible abnormality. And so what we did is that we basically scanned right over the SC joint, and you have to just ask the patients whatever makes the popping happen, we're going to do that in imaging. So I've had patients where I'm on the floor scanning up. I've had, so there's many different things you might have to do, but you can see here that during this motion, the clavicle just popping out. And so we were able to confirm that the popping sensation is not muscular. It's not anything, vascular. It's clearly the clavicle popping out. So this is sternoclavicular dislocation. Another interesting one. So this was a newborn. Funny film. Lot of periosteal reaction, really robust callus formation. This actually was confusing. So someone looked at this and thought, well, is the joint dislocated? Like, because in newborns, you don't have any of the ossification, the epiphyseal ossifications in there. So if you're not quite used to reading this, I think this came from the outside. Someone said there could be an elbow joint dislocation. But if you've seen this entity before, you know that it's not actually a joint dislocation. It's something else, and we'll show what we can do. So we don't want to put a newborn under MRI. So offered to do an ultrasound. And this case, I hadn't done one before, so I had to kind of go to the normal side first. Here's from posterior. So the triceps tendon attaching to the olecranon apophysis, right? So it's cartilaginous. You see the back of the humerus coming down, and you see the trochlea here. So this being the ulnohumeral joint. Here is the physis, right? Right? Then I looked at the radiocapitellar joint on the normal side, and I said, okay, it sort of looks like a golf tee. So you have the radial head ossification center, and then you have the capitellum. So here's the capitellum, here's the radius. Everything's lined up on the normal side. When you go to the affected side, again, we're going to see all of this callus formation. First, I looked at the ulnohumeral joint. Well, I know that if this is the trochlea and this is the olecranon, and the joint itself is intact. And then I went to the radiocapitellar side, and you see the radius aligned with the capitellum. So there was no joint dislocation. Confirmed that there was no joint dislocation. But what you can see here, here's the humerus, here's the physis, and here's displaced trochlea, right? Like this should have been down here. And so what you're seeing is that the fracture is at the level of the physis. So this is a transphyseal fracture, which I'm sure you have seen. So the fracture is through the growth plate. So the epiphyses shift relative to the metaphysis. But on an X-ray, because we can't see the epiphyses, it just looks really funny. And so it can look like a dislocation. This was a nice way to very confidently tell the surgeon that this was not a true joint dislocation, and another example of ultrasound. How about some pitfalls? So you look at this case here. Here's a knee ultrasound where we're showing the quadriceps tendon, something here, and then the patellar tendon, and then something here. And so on the outside, there was one time I saw a case just like this, and it was called synovitis or effusion. But remember, this patient is like 2 years old in this case. And then what is this here, right? Is this a fluid collection? Remember, this is normal unossified bone. So this is the patella ossification center, and this is the tibial tubercle. So if you're not aware of this, if you're doing more adult imaging, for example, you could run into this. And so you have to adjust the gain on the ultrasound to show that it's actually not anechoic. It's more likely just hypoechoic. Another example, where you're assessing the wrist in this case. So here's a distal radius, here's the growth plate, here's the radial epiphysis. And then you have two kind of dark spots. What's going on? This was a ganglion cyst, and this is just unossified bone. So just remember that you have the unossified cartilage that can really trip you up when you're first starting to do MSK ultrasound in smaller children. This is another one that I think when I was first learning ultrasound really tripped me up. So when you're looking at the wrist tendons, for example, in transverse on this side versus in longitudinal, if you are getting a rheumatology case and you kind of just look kind of too proximal, you might think, oh, this is tenosynovitis. I see a dark thing around the tendons. But then when you look in long, you see that it's actually just hypoechoic muscle. And so that is a common pitfall, I think. And so as long as you kind of scroll more backwards or proximal, you'll see that it's actually just a myotendinous junction. Here was an example of a unusual mass. This is a posterior elbow mass. It looks solid. What is it? Has some flow. We were confused, did an MR, and it just looks like a typical venous malformation, lobulated margins, a little phlebolith. So there definitely are pitfalls. And these venous malformations can look kind of more confusing sometimes if they're surrounded by muscle. So why do I do ultrasound? Why I think it's good to learn ultrasound? There's no sedation, no contrast. You can do a dynamic evaluation. You can do motion. You can do stress views. You can do compression, Valsalva compared to the other side. You can confirm clinical suspicion for your providers, and avoid MRI. And it can be helpful if there's MRI artifact issues and diagnose benign masses. So I'll pause there and kind of break it out for some questions, and then we might have a second part depending on how much time we have.
Yeah, thank you, Jonathan. That was very fascinating. I feel like it's this whole new world of ultrasound that I need to explore. So I'm definitely interested in asking you some questions. I have one question from the audience so far. If anybody else has questions, feel free to direct those to me, and I'll incorporate them into our talk here. The first question was about that median nerve entrapment case. Did you kind of have a differential going into that? Were you kind of just going into it with, there's something weird going on here, I'm just going to see what I can find? Did you have that in your mind of, maybe this could be entrapment?
I did not even think entrapment. I had never really even heard of that before that case. I was kind of more thinking, if you had a bad both bone forearm fracture, could it have kind of just spiked into the nerve at the time? Maybe there was going to be a nerve injury or some thickening. But that was not. I was scrolling, kind of was like, what is going on? So it's really fun too, because if you love the diagnostic part of radiology, right, like as we all probably do, it's like really cool to see a case where there's a very high pretest probability going in, and then just kind of seeing what you're going to see. So
thank you. I'm kind of just thinking, I think you make a very compelling case for why we should be using this more often. And I'm kind of thinking about it from the lens of my personal perspective of how our hospital's set up and how we could incorporate some of these things. So I'm curious if you have input on some of those types of logistical things. One thing I'm thinking about is, I feel like it seems like there's probably some dividing line where sonographers could do some of these exams independently, looking for effusions and things like that. It seems like we could train them to do that by themselves. What percentage of these exams that you showed are you, either you or one of the other radiologists kind of personally involved in, versus how much independence are the sonographers able to achieve with these kind of more complex exams?
yeah, Definitely a very good question, very practical question. It takes a lot of time for them to get comfortable with it. It's totally new anatomy. Just like us, they're kind of, more cautious or afraid to kind of do an exam they don't want to do. I think for ganglion cysts, for effusions like that, I think that first step is a lot, it is like much more doable for them to do, and even without you having to go in the room. Once you get into tendon injury, nerve injury, then I do go in the room for every one of those cases. They're not at the point yet where they can do that. Even on the adult side, the sonographers who do it every day, I still might have to go in the room, but it takes years for them to kind of get, and it depends on the referring practice, right? How many they get. But I tell them, like, you guys are doing liver Doppler on like a 6-month-old baby. Like, if you can do that, you can do, these things are not moving, they're not pulsating, you compare to the other side. So I try to really build them up the confidence. The other thing is, we have a lot of offsites, so depending where you are.
Right. That's kind of what I'm thinking of.
So what happened with us is that we had a few sonographers that were at offsites, and they might look at their list for the day and be like, oh my God, an MSK case. And that's not ideal to have them by themselves for a case like that. Sometimes if they're very comfortable, like there's certain exams, you kind of have to decide. We kind of made a decision like a year or so ago to say, okay, just funnel everything to the main. Like, even though it may not be quite as, convenient for the patients, but to have a situation where you have a radiologist talking to a sonographer to feel comfortable.
Right.
So we made a couple of half-day assignments dedicated at the main, and we try to funnel all the cases into there, and that's been working really well, because then you can have your team of sonographers that want to do MSK and make sure they're on site that those half days, and it really helps a lot with the development of the MSK.
Right. That makes sense. And I'm kind of thinking, we have, so many sonographers, 30 plus, and do you have kind of a subset of sonographers that do all of the MSK, or is it kind of everybody has the option to do it? Or?
So it's very key. I think it's good to have a small team, to develop a small team. We're developing. We have one person who is like sort of our ultrasound champion, who took the special certification. They have the sonographers have an MSK certification they can take, and I've worked with her like very closely over the years. It's good to have other people on board. I think for like joint effusions and for lumps and bumps, like everyone can kind of do that.
Yeah.
But yeah, developing a team of people, I think, is really key. And it gives them confidence too, like they have something special, like a little feather in their cap. And I think that is actually good if you can try to build that up, if people are interested.
Then kind of a continuation of that question, we have, 20 plus radiologists that are in the pool of people who are reading ultrasound. We have about 6 people that also have MSKs, subspecialty expertise. Do you only have the MSK people involved in these cases, or is it just you, or like, how do you kind of?
Right. So, we've kind of tried to siphon off the high-end MSK ones to just MSK docs.
Okay.
Because like we're more familiar with reading the MRs, and so it kind of makes sense for us to read them. General ultrasound, of course, in peds, there's MSK and like a lot of things, right? Hip ultrasound, you can't have people not even know how to read a hip ultrasound in 5 years. Right. If they. So, for effusions, for ganglion cysts, for hip DDH, whatnot, like that goes to the general. But like, for example, I'm on MSK today where I'm reading like MRI mainly, but then if it's an MSK ultrasound, then I didn't want to do it. So that I think is more ideal. And we also have the option if someone's on general and they get a case and it's like a ganglion cyst, but it turns out it was like a little more complicated fascial arthritis case, they can call and say, hey, would you mind taking over this case and kind of helping me with the case. So we kind of have that kind of back and forth communication as well.
And do you schedule these exams on specific days with specific people? Like we kind of tried to do that with contrast ultrasound when we first started it. We had a few sonographers and a few radiologists that had a specific interest in kind of learning how to do it. So it was always just kind of messy to have the schedulers, look at our schedule, look at the sonographer schedule, and try to match everything up. So I found that challenging. Is that something you guys are doing with these MSK ones?
So in the beginning, it was all over the place. We had MSK ultrasounds that could appear any of our offsites, and we would get a phone call like from a sonographer, like SOS, I don't know what to do, you know, and then finally, like I worked with Martin, our ultrasound manager, to say, okay, we have to limit, they can only do these procedures at the main hospital, and we picked 2 half days where those are MSK dedicated slots that are
Okay.
saved for MSK ultrasound. And the other thing that we did that I think was really helpful is that I don't know how it works with the procedure code. So for us, everything used to be called like non-vascular
Right. Yeah.
extremity.
Yeah.
And then I was like, guys, like we don't even know what we're imaging. We have to, similar to like in cross-sectional too, like the more specific you get, the easier it is for schedulers. So we created like 20 new orders. It was a pain, but like it has the letters MSK in it. So if it's, so you know, in ultrasound, there's the complete code and there's a limited code for ultrasound, only 2 codes, like 705, 78
Right.
or something.
Yeah.
So we created like ultrasound MSK knee, ultrasound MSK wrist. And so that way, then all of the sonographers can see when they're looking at their schedule ahead, it says MSK, and they're like, oops, that was maybe not put in the right spot, or that has to be. And so that was very, very helpful. So you first have to kind of like rein it in a bit to kind of create the service. And that's a big thing as well, too. So limit it to a couple half days to start, change the names of the orders. Advertising, marketing, like I sent out like emails to any provider that would possibly use MSK ultrasound. So rheumatology is a big one, sports med, PM&R, the nerve surgeons, plastic surgeons, those are ones as well. So you kind of think about anyone that might order an ultrasound and kind of just describe like what are these things that you can do, because they don't even know what is even available, right?
Right. That makes a lot of sense. Yeah, I'm just thinking, we have, like I said, we have 6 MSK radiologists. We have 4 different campuses that ultrasounds or really 5 that ultrasounds are being done at. Only 4 of them have a radiologist on site on any given day. So I feel like there's a lot of moving parts, but the advice you have is very practical. I think it
Yeah,
really
I think
makes a lot of
you
sense.
want to start where the radiologist is on site, because then you come in the room, the sonographer feels more confident. And actually, you know so much MSK from reading MR, right? That
Right.
sometimes you go in the room, you talk to the family, and you kind of figure out what it probably is, and the ordering provider doesn't even know what it is, right? So, and it really it. I know it's always people always say history and physical are the most important. You know, I hate hearing that thing over and over again, but it really is true. Like you know, if someone like cannot move their thumb, you're like, okay, that's going to be flexor tendon, right?
Right.
If you feel a nodule, it's going to be. Oh, I should have shown that case. I have another one of the trigger thumb. You know, like there's things that are just, and also, it just really helps you get a better appreciation for MSK.
Right. No, it makes a lot of sense.
I see a question there about slipping rib. So a slipping rib question mark. It is a hard exam. I've done it. I've been asked to do it quite a bit. I've only felt really confident about like maybe 1 or 2 diagnoses over the many times I've been asked, because it's very tricky. You have to have them do multiple things, sit-ups, this, that, turn this way, turn that way. They have to, with any dynamic abnormality, if the patient can't reproduce it, it's very hard to show it on imaging. So but yes, you can do ultrasound for slipping rib. And a case we had recently, we didn't necessarily see a slipping, but we said, well, hey, if you have pain there, we can offer, our IR guys offered a nerve block. And so I just went up the day of and just kind of showed them which rib and kind of the area and things like that. So
Yeah. Yeah. We've done a couple of those too. And there's a really nice video on YouTube, but somebody presented it at AIUM and then it got uploaded to YouTube that I always rewatch every
I
time
feel
I
like
get
I
a
may have
disorder.
watched one of
Yeah.
those. Yeah.
It's really
It
nice
always looks
images and
like
really
so
nice
perfect.
description of like how to do it. So that'll be a good reference if you guys want to learn a little bit more about what
For
that looks
sure,
like
for
and how to
sure.
do it.
Yeah, but there's a
Um,
lot of little things in MSK, and I think it's just important to be okay that you might do the exam and not find anything. And I think clinicians are still like very appreciative, because you didn't really like lose much. You didn't give contrast, you didn't get sedation. They may have to go to the OR anyways, or they may have to, get an MRI anyways. So that's kind of how you started up.
yeah. Yeah. That makes a lot of sense. Like it's not super expensive. And there's not a whole lot of, you don't lose a whole lot by at least trying ultrasound. So
Exactly, exactly, exactly. And I think the low-hanging fruit is like nerve and tendon injury. Those are kind of the big areas that you can really add a lot of value right away. So when you're talking about nerves, I feel like the upper extremity is you're more likely to get a case of an upper extremity nerve injury, just because you think of just the hands and the arm getting fractured and injured. That's what you might get. So when you think of the nerve, just remember that similar to an Ethernet cable, you have multiple fascicles inside of the main nerve sheath. So the outer covering is called the epineurin. And then you have these fascicles, right? In between the fascicles in orange, you have what's known as the inner epineurin. It's like this connective tissue. And then around the fascicles, you have what's known as perineurium. And around the individual axons and myelin sheath, you have endoneurium. So there's a whole kind of stratification here. And what we're trying to do is classify the nerve injury. We want to help the surgeon decide, is this something that is non-operative or is it operative? And so what we can do is really try to just figure out what's going on. So here's just an example of a normal nerve, right? Very, very zoomed in. All these little black circles are the fascicles, right? This hyperechoic rim is the epineurin, the outer epineurin. And then in between, you have this connective tissue that contains fat known as the inner epineurin. So that's the nerve structure. It kind of looks like a little honeycomb. And if you're not sure if it's a vessel or a nerve, you can turn color on and this will, of course, not light up. Here is just an example of the nerves you are going to look for, right? So you got your median nerve. It's going to cross the elbow in the midline. It's going to go to the carpal tunnel. You have your ulnar nerve on the inner side. It's going to go behind the medial epicondyle, and it's going to be in the cubital tunnel. And then you have the radial nerve, which is a little bit more of a difficult course. So it goes posterior to the humerus. So if you have a humerus fracture, something that will get affected up here. And then at the elbow, it does an interesting thing. It splits into two branches, the posterior interosseous nerve, or the pin, and the superficial radial nerve. So it really depends where you're looking. So I sometimes will switch probes during the exam. If it's more superficial, I'm using the highest possible frequency. And then as the nerve goes deeper, you may have to switch to lower frequencies. So here's just an example of me just sort of tracing multiple different nerves. Here would be the median nerve at the elbow. Here's the median nerve at the wrist. Here's looking at the cubital tunnel at the elbow. Here is a superficial branch of the radial nerve. So you learn to kind of trace these nerves. And as with all of MSK ultrasound, there's all these advantages of being able to, compared to the other side, no sedation, as we said. One thing that's nice is you can trace a nerve over an entire extremity. So if someone comes in with an ulnar nerve palsy, they may not know exactly where the site of the injury is. They might know the region, but what you can help them is you start up at the shoulder and go all the way down, and then you can tell them exactly where the injury is. It does take a high skill to kind of like learn it first. Sort of the trees, not the forest. You're very zoomed in. MRI is kind of better for the denervation changes that will happen if you have a nerve injury. And of course, it's only superficial. So let's go through a couple of nerves just to kind of see where we're going to be scanning. So for the radial nerve, here's just a picture at the elbow, and you can see this was similar to like an axial MR, right? So here's the brachioradialis, here's the radial nerve, here's the brachialis, here's the distal humerus, you can see the cartilage here. So it's nestled kind of on an angle here along the lateral part of the elbow. Then it does something interesting. So it splits, and you get this little snake eyes look. You'll have the pin and the superficial branch. And so the pin will kind of wrap around the supinator muscle as a very distinct look. And when you switch into longitudinal, you can see it has this normal little divot here. That's just a expected thing. That's right where it dives into the supinator muscle, the arcata froge. And that's an area where you can have impingement. Then we look at the median nerve, and what I tell the technologists is, hey, it's right near the brachial artery. And they all know how they're all so good with vessels that they've seen this nerve. They just never really looked at it carefully, but they're much more aware of the median nerve because it's near where they do their vascular workup. And so here's the median nerve at the elbow. Notice how it's on the opposite side of the radial nerve. And then here at the wrist, you can see the median nerve and the carpal tunnel. Here's tendons. They look different than the median nerve. And this is the carpal, this is the flexor retinaculum. Okay. In longitudinal, you see the nerve has a different appearance than tendons. It's more hypoechoic, you can see the fascicles, and you're looking for any kind of pinch or narrow. Now, the one that you much more commonly are going to be asked to evaluate in peds is the ulnar nerve. So they always want to know, is the ulnar nerve at the cubital tunnel subluxating? What's going on with the ulnar nerve? So you put your probe in transverse. And what I do is, I think the best way is to just feel on the patient, feel the medial epicondyle, most superficial bony bump. Everyone knows they have the bony bump. Put the probe right over the bone. And what you're going to see is a picture like this. You're going to see the medial epicondyle is more superficial one, olecranon is posterior. The nerve is sitting right in between. And then in longitudinal, you're going to see the nerve coming down here like this. Here at Guillen's canal, you see the nerve here next to the ulnar artery. Now, when you're doing the dynamic, it takes a little practice, but again, you put the probe over the bone. You start off in the extended position, and you ask the patient to slowly kind of flex up the elbow. And as I showed earlier in the talk, what will happen sometimes is that as you're following it, again, stay over the bone, the nerve may pop out. So here it's like a little bit perched, that's kind of halfway, but then follow this little black thing and all of a sudden you see it pop over. And I always ask, do you have any symptoms when this occurred? Do you have any tingling? This can be an asymptomatic finding, so we don't jump to that this is 100% the cause of your problem. So I always ask them, does this produce your symptoms? Surgeons like to know it because if they're planning on doing an ulnar surgery, they might have to do kind of a transposition to tack it down if it is subluxating. When you're looking at nerve injury, it sounds really complicated because it is when you're talking about a pathology of nerve injury under a microscope, but for us, you kind of can break it up into a few different categories. So you have low grade, which is often non-operative, and you have high grade. High grade is usually operative, and there's improved outcomes with early surgical intervention. So we want to diagnose high grade injuries. So if someone has a nerve injury, the problem is EMG can take months for the downstream effects to appear. They may not even be able to get in for EMG. So one of the first cases that I ever did, the hand surgeon or plastic surgeon called me and said they're not even getting there's no appointment until 3 months down the road. Is there anything else we can do? We can do an ultrasound. I was like, sure, we can try. And also the nerve conduction studies where they want to see if there's any electrical activity across the nerve can be misleading. So if you have like a severe stretch injury, the nerve can be sort of stunned, so to speak, and you may have like a severe neurological deficit, but it's actually still intact. It's still continuous. So that's where ultrasound can really add value because you can see if it's transected or not. And if you don't repair it by 6 months, there's much more poor recovery. So children have a greater spontaneous recovery. So it's really, really good to try to, one, localize a nerve injury and just distinguish high and low grade. So what does that mean? So low grade, you're going to see a normal or thickened nerve, right? These two high grade things that I want you to remember is neuroma incontinuity and complete transection. So let's show what that looks like. So in this patient who just has ulnar-sided pain, the nerve is a little bit thickened, but it's still continuous, right? This was a low-grade injury. Now let's get into the high-grade injuries. Now I'm going a little bit fast. Here is a neuroma incontinuity. So the nerve is continuous, right? It's not a complete laceration, but you see it's losing that fascicular architecture. It's nodular, it's hypoechoic. So this is what's known as a neuroma incontinuity. It's an area of disorganized repair, fibrosis. It's not a neoplasm, even though it sounds like you're saying neuroma, but it's just a scar ball in the nerve. And this was that case I showed you before with the neuroma, and this is comparison to the other side. Here's another neuroma incontinuity. This patient had a soccer injury. This is the median nerve of the elbow. See this focal nodular fusiform enlargement. If you see that, that's more than a low-grade injury. That's a high-grade injury. Needs surgery. This was a patient, again, with a neuroma. So had a very large nodular thing. And then you see the more normal nerve distal here. This was a complete transection. Okay, so you're following the nerve and you see a neuroma, an end bulb neuroma. Wherever it gets cut, you usually get a neuroma, and you see a big gap, and you can actually measure the gap. And then you see the distal nerve. This is another nerve, same patient. This looks like a vascular clip. This is a nerve coming down. Nerve is completely cut, and this is the distal stump. So you can map out these injuries for them. Here was another injury of the posterior interosseous nerve. You can see nerve coming down in blue, gap, fluid gap, and nerve distal to that. You see a hole where you normally see nerve tissue. This was a really striking case of 5-year-old lacerated wrist against the window. And you see the median nerve coming down. All of a sudden, you see a big neuroma. All right, so you know there's definitely already at least a high-grade injury, something 4. Now you have a complete gap, and the distal nerve is reflected. So it's showing them that this is a complete transection, and that this is a surgical case. This is a patient with a claw hand, had a repair at some point of a nerve, but was lost to follow-up. And you can see as you're following the nerve down, it sort of ends in this little nodule, right? And so when we did an ultrasound, you can see the nerve coming down, focal nodule, so at least a neuroma, blind ending. So this is a complete transection. And basically the thought was that the surgical site, there was a dehiscence. Here's a gunshot wound, so couldn't get MR to really answer the question. Has a wrist drop. So you have to remember, it's kind of fun because you sort of remember some of the neurologic abnormalities that go with each nerve. So wrist drop, right? Because you lose your wrist extension. We know that's the radial nerve. So remember we said the radial nerve comes behind the humerus and goes down. So of course, this is right where that could affect it. And what I did is I went in there and I just started from normal, traced the nerve down, and then I kind of lost it. Sort of just see these frayed fibers right at the fracture site, couldn't really follow it. Then picked it up again and saw like a discontinuous nerve beyond the fracture site. And so this was a complete transection of the radial nerve. And I showed you this case already, I'll move on. Oh, this was the MR of that case. You can see the nerve kind of is pinched in here, it's tethered into the bone. You see it go in and then come out. So just in conclusion for this part of the talk, really ultrasound is an excellent for MSK ultrasound, especially nerve ultrasound, and can be very helpful, and you can do it. So